Hello, everyone. Welcome back to another episode of Forward Physio. Today, I am very, very fortunate to be here with Steph Mundt, who is a physical therapist in Phoenix, Arizona. And I've listened to a bunch of podcasts like the E3 one and the Movement Optimism podcast with Steph. And I've really, really enjoyed them. And I told Steph right before we started that I'm excited to actually have her on today. Steph, before I get you to introduce yourself, I want to ask you a question that I've asked some other people in the past. If you could instill one trait into a new physical therapist, what do you think that would be?
This is a great question. I think it would be curiosity. And I'm going with that because as a new grad myself, I think I felt the need to have the answers immediately from what someone told me and come up with a plan. Um, but I know, and I'm sure I still do this, there are so many questions left unanswered that could kind of bring that to me, or the patient then could answer themselves. So I think getting curious about what's going on in that person's life, what might have contributed to this, their current situation, and also curious about how they view movement, exercise, that relationship can go a long way.
Mm-hmm. Cool. Do you feel like you have tried to work on your curiosity throughout your career? Is that something that is really natural for you?
I think I've worked on it. Um, I think coming out of school again, it felt very much like I need to have these specific things for someone as soon as they come in. I've got X, Y, and Z for you to complete.
Mm,
Or having assumptions about how they feel about certain interventions or about their body or about movement and exercise. And so I think it has been a work in progress of, instead of, oh, I have a solution for that, saying like, I'm curious what you think about this, or I'm curious how that made you feel when the doctor told you that you had bone on bone,
yeah.
and getting a little bit more into kind of their perspective rather than just assuming.
Asking some more open questions and actually letting them say what they're thinking a little bit.
Absolutely.
Cool. Well, I am really, really, really curious about bone stress injuries. I don't see a ton of them in my practice. I hope that's not because of my terrible diagnostic abilities.
Sure. No.
Yeah, I'm always on edge for them, but I just happen to not see a ton of really, really avid runners and maybe some of the other populations that get bone stress injuries frequently. Um, and that's what we're here to talk about today. So, can you give us a little bit of a background into who you are as a PT and your professional interests and how you got into bone stress injuries in the first place?
Yeah, absolutely. So I am a physical therapist and a running coach as well. So sometimes there's some overlap, managing niggles, aches, and injuries. But I also coach athletes to marathons, up to ultra marathons. And I've been a physical therapist for 8, almost 9 years now, which is crazy to think about. But I got into I got more interested in the rehab world, as many of us do, because of my own injuries and my own experience. And of course, it follows that I experienced several bone stress injuries growing up. And at the time, it was, I think, probably a lack of research evidence, a lack of knowledge on the part of my clinicians as well. But the response was just rest for 6 to 8 weeks and then start running again.
Mm.
And now looking back, of course, hindsight's 2020. I had a very severe eating disorder that was likely the root of these injuries. And instead of that being addressed, I was told my hip flexors were tight or I needed a heel lift. And at the time, I loved those explanations. It really fed my eating disorder of, great, I don't have to address this aspect, even though there's kind of that underlying feeling of something's not right here, but I can keep pushing that away and continue to work on my hip flexor length and my leg length discrepancy. Those things must be causing these issues. And again, I think there's been a lot more research lately. Female athlete triad was known, but probably not as well talked about. And now we've got this expansion into relative energy deficiency in sport. But as I started going through school, even though some of that research was coming out, we still didn't learn a ton about it. And I think that's consistent with a lot of other physical therapist experience, to my knowledge. Did you learn a lot about bone stress injuries in school?
Not at all.
Yeah.
Not like I'm being serious. Not at
Yeah.
all.
Yeah.
Yeah.
So even though and what year did you graduate?
Wow. 2022.
Okay, so
Yeah.
even recently, I was
Yeah.
2017, and it felt like coming out of school, that was part of my reason for going. I wanted to figure out, selfishly why they kept happening to me and how I could run without them, and then also how to help others with them.
Yeah.
And, same thing, we didn't really see them as part of our differential diagnosis, and that's probably why they're misdiagnosed quite frequently.
Mm.
The we didn't talk about exercises specific to them or anything like that. And so coming out of school, even though I had recovered from my eating disorder, I was continuing to run, continuing to get bone stress injuries. So even the very little that we had didn't seem to translate into clinical practice or reducing the risk of these injuries in the future. So I just started doing more research, found clinicians who specialize in this, and I've learned a ton from them. And now I am getting involved in research, and I started a PhD program. So hopefully we'll have more information on these injuries, and not only the risk factors, which might be important, but also just how to manage them and reduce future risk.
Yeah, and I think a nice structure for the podcast will be to talk about those risk factors and then eventually management. Um, and one of those risk factors, you mentioned it in your story there about how maybe the eating disorder can be related to the onset of a bone stress injury. And you mentioned how those explanations that we gave a lot of the time, like, just add a heel lift or your hip flexors tight, you actually kind of liked them because it allowed you to bypass sort of what you truly knew. And I feel like that's a really, really important note there, that may be the same with other patients that we deal with when they have these certain behaviors that may be a risk factor for their injury and they have been exhibiting them for a long time. It's really not something that we could just easily brush under the rug, and they may, whether it's consciously or likely subconsciously, sort of grasp onto these other diagnostic explanations. So I think that's a really, really important note that you touched on there. um, so can you explain why something like an eating disorder may be a risk factor for developing a bone stress injury, and how we go about having those conversations with somebody? Because it's really out of our scope of practice a lot of the time, right?
Definitely is. Yeah. So I think that it's important to note that eating disorders themselves can lead to the circumstances that put you at higher risk for bone stress injuries, but that's for the same reason that unintentional underfueling, disordered eating habits and behaviors, there's evidence that these kind of tendencies and actions that aren't necessarily clinical eating disorders can still have an impact on our bones.
Mm,
And that's because when we are in an energy deficit, so essentially we're not eating enough, taking in enough calories to meet the demands of our life and our sport. When that occurs, it kind of triggers these hormonal changes that then lead to sometimes changes in the reproductive system. So in females, we'll see a loss of menstrual cycle. Sometimes you can also be in an energy deficit and have a perfectly normal menstrual cycle. In males, we'll see a decrease in testosterone. But essentially, it sets off this cascade of events that then reduces your bone's ability to recover. So it reduces bone formation markers, can increase bone breakdown markers. And each time we exercise, we're getting a little bit of bone damage. That is the stimulus for it to remodel. And so each time that we do a certain level of exercise that causes some damage in the bone, we need some time for that to rebuild. But when you're in an energy deficit, you don't get that rebuilding. So you get this accumulation of micro damage that then can lead to a bone stress injury,
mhm.
which I think that's probably another term that needs to be defined. A lot of people have heard of stress fractures, but not all bone stress injuries are fractures. They exist on this continuum that goes from kind of the start, where we see some edema of the outside of the bone, then edema in the bone, and then can progress to an actual fracture. So I think important to note that that's probably why these can present so differently
Mhm.
and have very wide ranges of symptomatology, whether that's severity or just kind of the way that people describe them. can be very different. And I think in part because there is a huge range of severity, and also just because we know people's pain experiences differ so much.
Yeah. Yeah. Not to mention that there's so many different locations that they could be experiencing these in, right?
Absolutely.
Makes it
Yeah,
pretty tricky to spot.
definitely. And so to your question about how we manage those, I think our role as physical therapists is more to screen for a state of low energy availability, not necessarily an eating disorder. That's definitely outside of our scope. There are some screening questionnaires that can differentiate between subclinical disordered eating and eating disorder. But the way that I see it is just checking for assessing for low energy availability. I use the left Q questionnaire, and there's a scoring system. So that kind of gives you some objective data of like, all
Mhm.
right, are they at risk for low energy availability? If so, I'm going to refer them to a registered dietitian. Now it's their role to determine, is there an eating disorder involved? Do they need additional help from a healthcare clinician? Or is this unintentional underfueling? So really, I think our biggest role is to know about this, to refer appropriately, and then collaborate with these other players to make sure that they're appropriate for continued exercise or not.
Have you ever gotten any pushback from patients when you said, "Can I refer you to a dietitian?"
Yeah, frequently. Um, I think there is a certain level of rapport and trust
Yeah.
that needs to be established in some cases, but that can also be a little bit of a hint, you know? And I think we need to make sure like we set aside our biases too, because there are eating disorders that exist without kind of what maybe we picture as an eating disorder, right? And so I think assuming that most endurance athletes coming in are probably underfueling unintentionally is probably safe. And
Mm.
so I will definitely refer out for certain types of bone stress injuries, or certain scores on left Q. But otherwise, I'll often say, hey, I want you to check in with this person. I think it'd be really helpful, not only for your health, but also for performance. And if they give pushback and there's some other kind of signs like their left Q score is high, that may be another sign that they're not ready for it. And in that case, unless it is a trabecular site of injury that's more associated with restrictive eating and a severe bone stress injury, I'll let it be, and just keep bringing it up. So kind of pester people, email them. Have you checked in with this person yet?
Yeah.
But there are times where I make it a requirement that they see a
Yeah.
registered dietitian. We'll kind of get to that when that's the case. But
Right.
either depending on I think the need for it, whether it seems like this is really playing into their injury, then you have to do this. If it's like, okay, we might be okay, their scores are low enough, they're at lower risk, then let's sit on it, but I'll just kind of keep nudging.
Yeah. What are some questions on that questionnaire?
So it goes through previous injury. So a history of bone stress injuries is going to be one that kind of adds up points. It also goes through GI function. So some symptoms of low energy availability are things that sometimes lead people to cut food out, which is
Mm.
problematic. Bloating, stomach pain, stomach aches, constipation. Those kinds of things are often, I think, misconstrued as like, all right, let's do a like restrict food and then slowly add it back in, which just adds to the issue.
Yeah.
And obviously, we're not going to tell someone how to do that, but I think it's important that athletes know like your bloating, your stomach discomfort probably doesn't mean you need to restrict more.
Mm.
And that's a definite referral to an RD. So it has questions about GI function, injuries, and menstrual function. So there is a LEMQ specific to males. It's not validated yet, but you can, get some information from the other questions that they can answer.
Yeah.
But loss of a menstrual cycle, if menstrual cycles are irregular, if they're longer than 35 days, or if, they change as training ramps up, there's just some questions on there that add to that score.
Got it. Okay. All right. So, let's say we have referred someone to a dietitian and we're very comfortable with the fact that we could start going forward. Are there any other like risk factors that you maybe have in the back of your mind when working with someone with a bone stress injury that maybe you'd want to manage other than
Yeah,
nutrition?
yeah. If they have a history of bone stress injury, or they have a trabecular rich site of injury, which we have high risk sites and low risk sites. And we also have trabecular rich and cortical rich. The trabecular rich are more highly associated with what we think of as the female athlete triad or kind of the relative energy deficiency. So
Mm.
low bone density, restrictive eating, and menstrual dysfunction. So if they have a trabecular rich site of injury, like femoral neck and navicular are probably the most common we see in runners, then I want them to get a DEXA as well, so we can just get a sense of their bone health.
Okay.
And so if their DEXA shows low bone density, which is less than -1, it's kind of a scale that compares them to a norm. It's a Z-score. If they're less than -1, then their progression is going to be slower because that's a predictor of their return to sport time. So we just need to be a little bit more cautious with our progressive loading, knowing that their bone density is low. If it's normal, then we could probably go at a typical timeline.
Okay. Okay. Any other risk factors that you could think of?
Yeah, I think the like history of corticosteroid use. I had one athlete who had JRA, and she was on corticosteroids for a very short period of time, but that's something that's kind of festering as far as just the impacts on bone health, potentially long term.
Yeah.
Um, Life stressors too, this is something that often occurs in athletes who are, maybe perfectionistic a little bit, type A, and so I definitely want to take into account what the social impacts of their injury, the mental health impacts of their injury,
Yeah.
as well as just kind of their circumstances, how much help they have, because there
Right.
are also times where someone needs to be non-weight bearing, but they have 3 kids under 4, and we know that they're not going to be able to be fully non-weight bearing, or maybe they live alone and they kind of have to put some weight on it. So there are definitely, I think, life circumstances that we need to ask about that will help inform our rate of progression.
Got it. And I guess the overall amount of physical activity that they're doing as well, right? Like if someone is
Definitely.
an ultra marathon athlete, we may have a higher suspicion compared to if they only maybe they did their first run in 2 years and it was a 5K and suddenly there's a lot of pain. Is it fair to say that maybe that's
Definitely.
probably not a bone stress injury?
Yes, yes. Sorry. I think I was speaking more to things that we want to look for the rate of progression, but coming back to like a differential diagnosis standpoint,
Yeah.
definitely want to think about their training history. So, like you mentioned, if they just started running a few weeks ago and they're up to, 10 miles a week, probably less likely. These are
Yeah.
injuries that build over time and typically see higher incidence about 5 to 10 weeks after a significant change in training. So this is something when you're evaluating someone, if you're trying to figure out, is this a bone stress injury? Is it not? Asking about any changes in training, specifically increases in not only volume, but also intensity. Let's say, okay, now they started doing intervals 8 weeks ago. Those are things that you want to pay attention to, and not in the few weeks before, but more like a couple months before.
Okay, I didn't know that. That's really interesting. And I could imagine
Yeah.
that memory may be a little bit of an issue there when we're asking people to really trace back. So I think it'd be really
Oh,
helpful for dealing with runners and they maybe have like a Strava app or something like that
exactly.
with
That's
all
where
of their previous
Strava,
runs.
yep, yep. Strava is so helpful. The number of times that they try to, recall is hard. And then you ask to see Strava and there's this huge spike, right? 5 to 10 weeks before, you're like, oh, that
Yeah,
that might have been it. Yes. So that's, I think, coming back to more of the risk factors for when you're trying to decide, is this person at high risk or low risk?
right, right. Why is it that there's that 5 to 10 week delay? Does that have something to do with like inflammation kicking in and that edema is starting to kick in?
I think it has to do with the way that bone remodels and turns over. So after like an acute fracture, it takes a while for essentially the bone to get to its weakest point
Mm,
because we have cells that kind of come in and break it down before the bone building ones come in. And so after an acute fracture, it's weakest in the 3rd week post. And so bone just seems to have this delay and takes a longer time to change.
yeah,
And we see that too with changes in bone density. So if you're trying to improve your bone health, it's not going to happen in, 3 months. It's probably going to take 6 months, at least six, probably even more like a year to 2 years to actually see incremental changes in your bone health when you're working on it.
got it. Okay. And I know you're differentiating between the high risk and the low risk sites and whether it's more trabecular bone or cortical bone. And you're saying trabecular bone is likely more tied in with those systemic factors like
Mhm.
an energy deficiency. Is it also more likely that they occur with overtraining as well? Or are we typically thinking it might be more cortical bone if it's an overtraining issue?
Yeah, I think it depends how you define overtraining because
Okay.
that overtraining, under recovery from potentially not eating enough
Yeah.
or, not having enough time for your bone to remodel, this can kind of be two sides to the same coin. So I think I see it more as the kind of foundations of health, like you said, systemically are less set and definitely need to be focused on before rebuilding training
Yeah.
in athletes with trabecular-rich sites of injury, whereas those with cortical-rich sites, usually more distal. So typically like metatarsals, the tibia, femoral shaft, those are going to be more of your cortical-rich sites, the long bones. Those we might see more of a role of mechanics.
Okay.
And then training could also be a part of that, of course, because of their repetition and their mechanics. There's likely still, I think my bias is there's likely still an energy component, but it plays less of a role. And that's an important distinction to make too, I think, because I know athletes in general, like there is a stigma against eating disorders. You don't want to be that person or even disordered eating. And so for athletes with repeat bone stress injuries, that are in cortical rich sites. I've had athletes be like, I feel like I'm eating enough, and people are looking at me like I'm just, I'm not fueling well, but I am. And so I think it is important to know that you can have a bone stress injury when you're fueling completely appropriately. And that
Yeah.
may be more due to just the overload of a certain structure because of a combination of training, mechanics, and the rate of increase of
Right.
your training.
Right. Okay. Fair enough. And what about things like alcohol or smoking or sleep? Are those things risk factors as well, or is the research not so clear with them?
I don't think that it has been researched a ton specific to bone stress injuries. Sleep is, or decreased sleep is a risk factor for general athletic injury. And specific to high schoolers, San Diego State just had a poster about this. Specific to high schoolers, the athletes in adolescence were at increased risk of just general injury if they got less than 7 hours of sleep a night. So I think that that is a fair assumption, but we definitely need more data to back it up specific to bone stress injuries.
Okay. Okay. So I think this is helpful for clinicians so that when they're doing their subjective history with the patient, they can start to understand the risk factors and the sort of things that may be at play involving, when may people be more likely to experience a stress fracture or bone stress injury. But what are some of the symptoms that they might be describing that may start to set off some alarm bells? And I know you mentioned earlier it could be a bit tricky because they could really range, right?
Yeah, and that's where having the kind of subjective history is so important. So, from that aspect, you're already starting to rule up or down a bone stress injury. Are they an endurance athlete? That's first. I think we all need to have it on our radar for distance runners in particular, gymnasts as well. A lot of these kind of like leanness or sports where
Mm,
the culturally a lighter weight is associated with being better at the sport. So first, we just need to have it on our differential diagnosis. Then, as you gather the subjective history, did they change their training in the past few months? Whether again, it's a lot of athletes don't change their volume, but they're increasing intensity, and so that is a significant change. Do they have a history of bone stress injury? That's a huge risk factor for another. Do they have normal bone density? Often when you don't know, but you can, if they have information on that, that can be a risk factor if it's lower. Have they had changes in their menstrual cycle, the changes in GI function? So thinking about these risk factors for low energy availability would rule them up for a bone stress injury.
okay.
And then you've kind of got this set on like, all right, how they told me then these things, either their risk is higher or I'm ruling it down. And now we go to the objective. Are they having pain at rest? That's definitely going to be something that is going to lean us more towards bone. When it's a more proximal site, so around the hip, pelvis, low back, it's generally going to be more vague and achy. So if
Mm,
they're like, it's kind of around here, or I've got some weird tightness this spot, They're not usually going to be able to reproduce it by pushing on it just because we have so much muscle mass. So more vague and achy around the low back, hip, pelvis. And then more distally, it might be a little more sharp and pinpointed. So if they've got discomfort, they're like, I've got pain at rest at this spot in my tibia. If I poke it, it lights me up. So
Hmm.
those can be some kind of descriptors. Night pain is a red flag. Most often, if it's progressed, you'll have pain at rest and at night. And then loading pain. If you're doing a single leg, just single leg stance first, because we want to start with the least aggressive exercise. If we think this is a bone stress injury, if we're like 90% sure, we don't need to do a single leg hop test. That's kind of the final step of a loading test. We'll do single leg balance. I'll do a single leg squat, double leg hop. If none of that's provocative, try a single leg hop. So single leg hop is probably going to be the most telling. But if they're even hesitant to go on that side, I call that a positive and don't make them do it. But a lot of these things can be positive also with, soft tissue. And
Yeah.
so that's where your subjective really comes in to back it up. And just critically thinking, is it reasonable that my distance athlete who is doing 3 to 4 mile tempo runs would have a hip flexor strain that's causing anterior hip and groin pain? Probably not. Not going to be as likely as a femoral neck bone stress injury. So,
Yeah,
taking into account that mechanism of injury is also going to add to that picture.
for sure. That pain at rest that people are experiencing, is that just when you're palpating it, or are they just feeling an ache that doesn't really go away no matter what they do?
Yeah, generally we'll just feel an ache throughout the day. Sometimes it can throw you off because it actually might feel a little bit better if they get up and moving. I've seen some athletes with BSIs at low risk sites who say that the pain gets better as they continue running, which we would think more aligns with tendon, right? But then you come back to,
Yeah.
okay, well, the site of injury, she's pointing to, she's got a vague ache in her thigh. It's probably not a tendon. So we can't trust as much. This is why the symptoms are so hard. I've had athletes describe it as tightness the entire time, or it just feels unstable. So
Yeah.
the if thinking about a contractile tissue, generally, unless it's severe and they have a specific mechanism of injury, it's not going to be painful when they're not contracting their muscle, right? So
Mm.
when they've got pain at rest, it's like, okay, that's just sitting around, and not just when you palpate it. That's could be something deeper.
Yeah, unless there's tons of inflammation, but normally that would be maybe
Mhm.
earlier on when they're first experiencing the injury, right? Like after a few weeks, it,
Right.
it typically will settle down a bit.
Yeah, yeah. And you generally have an associated mechanism that's like, oh, that's when I did it. I know that that's exactly what I did. I had that pain at that time, rather
Yeah.
than it kind of feels like it came out of nowhere or it started gradually or was fine and then it built as I kept running.
Yeah. I think some people may hear what you said about the squat and be a bit confused because they
Okay.
may think when someone has a bone stress injury, they immediately think impact, right?
Hmm.
And that why would a squat bother it? And maybe if it was a squat, that means it's contractile tissue because we're not
Such a good
loading the bone
point.
that much in that position. Could you speak
Uh-huh.
on that a bit?
Absolutely. Yeah. I think once it gets to the point where even single leg stance or single leg squat are painful, the kind of mechanical competence of the bone is lost. And so anything that puts some single leg load on it, or anything that you will have some light muscle contraction around the bone just to stabilize, but anything that requires you to load through that extremity is going to be painful and create a change in, I believe it would just be like a change in pressure in the bone cells, and that would create a pain response.
Yeah. Okay, got it. Okay. So I think those are some really, really good objective tests. Let's say you have, after that, pretty high suspicion that you're dealing with a bone stress injury. Are you then referring them out? Are you asking them to get an x-ray or an MRI? What do you do next?
Yeah, one thing I wanted to jump back to real quick, there are some special tests for bone stress
Yeah.
injury specific
Okay,
sites.
great.
So the fulcrum test for the femoral shaft, where you're just pushing down on the kind of close to the patella, and you've got like a block under the femur and bending that bone. So you could do that for other sites too, where you're trying to bend the tibia, bend the metatarsal, especially those long bones. And at the femur, that test is pretty good, pretty specific. So kind of circling back, there are a few special tests that can be helpful, but the weight bearing test and then the subjective piece are huge. If I suspect a bone stress injury, I'll refer them for imaging. Now, I know it's much easier here. We actually have imaging privileges in Arizona, so I can do it without sending them anywhere else. However, I know it's not that easy for in other states and in Canada.
Yeah. Yeah, for sure. I mean, that's one of my concerns when someone comes in the door and I need to get imaging. X-rays aren't too bad, at least in Ontario, as of what's the date? November 24th, 2025. PTs, we can't ask for imaging. We have to send them to a doctor. So there is a little bit of a delay there, or a walk in clinic, and then they could get a referral for an X-ray or an ultrasound. And that doesn't typically take too long, but the wait time for MRI can be months and months.
Absolutely. Yeah. So I think X-ray is not going to be helpful. That one, there's so many false negatives that it's just not super sensitive. So ultrasound at distal sites might be an option.
Really?
That's being used more for the like tibia metatarsals. So that diagnostic ultrasound might be an option if that's quicker. But for those more proximal sites, you'll definitely want an MRI to confirm. Knowing that the wait time could be long, if you suspect it's a high risk site, so femoral neck, you'll want to get them non-weight bearing and play it cautiously. It can be really hard to get buy-in when you don't have the imaging. But that site is of high importance, being a high risk site, which means that it has a chance to progress to a higher or more severe injury, a full fracture. Um, and so you want to get them non-weight bearing as soon as possible. And then I would just progress as if it is that injury, which does make it tough because you also don't want to have someone go non-weight bearing unless they absolutely have to.
Yeah.
Is it quicker if can you refer to ortho and then it would be quicker, or it's still the same wait time?
Um, well, I would have to refer them to a family doctor first, and then they would have to send them to
Then,
ortho.
okay, so it's all just,
It depends on the
yeah.
wait time for that ortho specialist.
Mhm.
But sometimes when people get in, they can maybe get one a little bit quicker, but not
Okay.
always, unfortunately.
Yeah, so that's where I think like this clinical reasoning is really important. And
Yeah.
it's hard to practice it when you don't see a lot of them, but if there's any even, 50% chance in your mind for especially a high risk site, then I would just have them go non-weight bearing and treat it as such until you have evidence otherwise. Of course, it's likely that they'll be progressing by the time they get the image, but that's
Yeah.
much safer than having them continue as if it's not.
Yeah.
For a lower risk site, if some of the tests aren't coming up as positive as you'd expect, and they're like, it's just, a little painful, maybe we'd think it's a lower grade, and it's let's say tibia, posterior medial tibia is a low risk site. Then you could probably progress a little bit less conservatively, still get the image, but use pain as your guide. They don't need to be non-weight bearing unless it's painful to walk, and gradually progress, but more quickly than you would a high risk site.
Got it. I have a couple questions. Firstly, just back to X-rays for a second. Are there any sites in particular that an X-ray can be useful for, or are there just a lot of false negatives, really, no matter what the area is?
Yeah, the sensitivity is pretty low regardless of the area.
Okay. Okay. The other question is, again, using that clinical reasoning, relying on that a little bit more in the absence of imaging. We want to maybe offload a bit more, like more quickly for a high risk site. Could we get a list of what sites are high risk?
Yeah, so femoral neck is again probably the most common in distance runners. And then if we move distally, the patella, which isn't super common, the anterior tibial diaphysis. So that one can be tricky because often I think shin pain is disregarded as shin splints.
Yeah.
So anterior tibial diaphysis is usually pretty tender to touch in the front of the tibia. They're more likely in multi-directional sport athletes or jumpers. But that's one that is more likely to progress to surgery if not treated immediately. Moving further down, medial malleolus, navicular is another one that's a little more common. The lateral talus, and the base of the second and fifth metatarsals. So there's certain areas of some bones that are more high risk. And then the sesamoid.
Okay.
I may have missed one or two, but I think those are the big ones.
Amazing. And some low risk ones? Posterior
Low
medial
risk.
tibia that you
Yep.
mentioned? Yeah.
Yep. That one's pretty common among runners. The femoral shaft, the a little bit more proximally, the sacrum and pubic ramus. Sacrum and pubic ramus are tricky though because they are more trabecular rich bone. So that's going to be kind of more of that spongy bone, like we talked about, more relative energy deficiency risk factors. So even though they're lower risk in terms of not likely to progress to needing surgery, they're still going to take longer to heal because of that trabecular rich nature. And you still want to ask those questions and be a little bit more intentional about referring to an RD for those.
Hmm.
And then at the foot, the metatarsal shafts are low risk and calcaneus. Calcaneus is also trabecular though too, so will take a little bit
Got it. And I find that it can be so overwhelming with all of these
longer.
different areas and knowing what to do for each of them, particularly as it relates to offloading. Do we do partial weight bearing, or are we completely offloading it? How long? Does that differ for different sites? And does that differ for within the same site but different grades of injuries? And sorry, Seth, to do this
Absolutely.
to you, but also, what if we don't have imaging? Does that dictate how we approach the offloading strategy?
100%. And that's why it's so tough, probably. It's hard to study. And why a protocol probably isn't, it can be useful from the perspective of guidance, but there's never going to be, I think, a specific rehab or return to run protocol for any individual post BSI because they're just so unique. So I think probably the best way to initially think about them is if it is a high risk site, regardless of the severity. So we don't need imaging. I mean, it'd be helpful. But even if you don't have imaging to show you the grade, if you're concerned about a high risk site, get them non-weight bearing, usually a minimum of 6 weeks. And so we need to be just very careful with these. Okay, so that's kind of the like, this is the hard line versus then we have the lower risk sites. Those you may or may not go non-weight bearing. That one we're going to be guided by pain. The high risk sites, we're not going to be guided by pain at first, just go non-weight bearing. The lower risk sites follow pain as your kind of North Star. So if they have pain with any activity, we're not doing it until they don't have pain with that activity. And the amount of time is challenging too because everyone's going to be a little bit different. And just because they don't have pain this day doesn't mean they won't a week down the road.
Right.
So I think with the progressions, you want to kind of take into account, let's say again, sans imaging. Let's say we know there's a bone stress injury. We think there's a bone stress injury of some sort. Let's look at the typical return to sport timelines for this site and then kind of break that into phases. So if typical return to sport for the, let's say, second metatarsal is between 10 and 14 weeks, and they're coming to us fresh, then we're going to break this down into a few different phases. And we know we're going to be full return or at least return to run, let's say around that 12-week mark, then we're going to work backwards. So we want them to be pain-free with doing regular activities of daily life in these first 2 weeks. Then the 2 weeks after that, we're going to progress to double leg loading and then single leg loading, plyometrics, and eventually running. So breaking it down that way, I think, can be really helpful. But that initial management piece, think high risk versus low risk initially, non-weight bearing high risk, symptom guided for low risk.
Got it. Okay. That makes a lot of sense. And you said at first, even for a high risk site, we're not really relying on pain. We're just offloading it. At a certain point, is it fair to say that if they do have pain, whether it's low risk or high risk, we're generally trying to avoid that at all costs during our rehab?
Absolutely.
We just sort of have a zero tolerance policy for that.
Definitely. Yeah.
Okay.
There are cases which are, I think, another tricky scenario. There are cases where someone might have a fracture on imaging. So if you do have the luxury of having that, but their pain is pretty low or they're not having pain, those are very unique and I think like special special cases. So
Yeah.
um there may be times where pain isn't the best guide for certain people, but we'll kind of set that one aside for now.
Right. Right.
Um,
If they have pain.
Right, if they have pain, right? And then there also is asymptomatic bone marrow edema that can show up on an image and that can be an incidental finding. So that's another thing that's kind of like an asterisk, but set aside for
I
now.
did want to talk about that. Let's set it aside and come back to that in a second.
Okay, okay. So, um, yeah, then we're really kind of using their pain as our guide to move forward, but intentionally with the knowledge we have about the typical timeline. So a lot of athletes will, they'll be non-weight bearing or partial weight bearing for a few weeks. Maybe they're in a cam boot. They come out of it. They're like, I'm fine. Can I run now? And that's where, right? Like they might be okay to go run right now, but if we look at their timeline, they just came out of a boot. This is probably not the smartest decision, especially knowing that we might get some pushback from bone 2 weeks down the road.
Right.
So we do want to avoid pain at all points and kind of use that as our guide, not only during the activity, but 24 hours later. And so if they have any return of pain in the moment or pain at night, at rest the next morning, then that means you need to take a step back in your program.
Got it.
Another asterisk on that, though, there are times where there's kind of like I call it like a bone reloading sensation to make it less scary, where when athletes get back into activity, they'll feel something intermittently, but it's not quite what they felt initially. It's not sharp, it's not reproducible. It'll happen like a random kind of pang at a various time. And if they're not feeling it again later in the day, the next morning, consistently worsening, then those are generally okay and safe to continue to work through. But it's always safer to take a step back in the program. If they're feeling something or are concerned about it, then try to just run through this.
That's good to know because I can imagine that could be quite scary for the person that's dealing with the bone stress injury or the inexperienced physio.
Exactly. Yeah.
Yeah.
Yeah. I've been there. You think like, oh my gosh, I did too much
What
with
have I
them. They're
done?
injured
Yeah.
again. Yeah.
Yeah.
But no, you could just take a step back, take a couple days off of impact, and then start back at a lower level than the one that seemed to be too much for them at that point.
Okay. Good to know. So you mentioned the asymptomatic bone marrow edema, and I've heard that we could have bone stress injuries that don't really hurt and they pop up on imaging prior to anyone ever feeling them, and that we should treat that similarly to a bone stress injury that is symptomatic. And I understand that line of reasoning because, especially for these high risk sites, the downstream effects can really be quite negative. So I understand being more cautious. On the other hand, I sort of like want to play devil's advocate a little bit and say if we were looking at a degenerative tendon on imaging that was never an issue symptomatically for somebody, are we going to tell that person to start behaving differently out of fear that that tendon may tear one day or develop some pain? What are your thoughts on that? Do you fall somewhere in the middle, or should we be more cautious, or should we just pretend that it isn't even there?
Yeah, great question. I think this is very contextual. So, for example, I've had 12 bone stress injuries in my life now. And now I've gone, knock on wood, 2 years without one. But anytime I have a weird pain, I am freaked out. I have the psychological effects of, oh my gosh, it's over. And so I've gotten some MRIs of body parts. Again, they're much easier to get here when I'm concerned about something that might be a bone stress injury. I had one of my left foot a couple years ago. I thought I might have had a fifth metatarsal BSI. And that side of my foot was clear, it was beautiful, but I had mild bone marrow edema of my first metatarsal.
Hmm.
Never had pain in my first metatarsal. And so I was like, oh, that's whatever. And I kept running. I was just happy I didn't have anything on the lateral aspect. Have not had any first metatarsal issues since. Um, in that, in that scenario, I didn't have any signs of discomfort. So that was probably just an adaptation my body was going through. Sure, if I had started having pain there, then I might have pulled back a little bit.
Right.
But now, if I had just randomly had an MRI of my hips and there was bone marrow edema in my femoral neck, I have a long history of bone stress injury. I have a history of eating disorder. That's a high risk site. That might be something where I'm like, I should probably take a couple weeks off. But I think it is contextual. I think there have been athletes I've worked with that get MRIs of both tib fib, because they've got pain in one, and it turns out they have a bone stress injury in the other. And
Mm,
so we are going to respect that. I'm not going to have them do single leg pogos on the side that they don't have pain on, because we know that there's probably some changes on that side.
right.
But we're not necessarily going to treat it as a bone stress injury unless there's pain associated for the most part.
Okay. Okay. That makes a lot of sense.
Yeah. But again, I think there's always special cases, right? Like
Yeah.
I've asked Rich Willie about this too, and he suggested that it's treated as a bone stress injury when you have pain and imaging findings. But again, there are special cases. If it was a fracture line that was asymptomatic, maybe we treat that differently.
Yep, for sure. And maybe if it's someone who's never had any bone stress injuries before, we could be a little bit less cautious versus someone who's had a bunch of them and it's in a high risk site. And it also coincides with a lot of, you know, a spike in their training recently. I think it
Exactly. Yeah.
makes sense.
But I think for the most part, we've all got some level of periosteal or bone marrow edema at different times if we're training.
Yeah.
And to kind of potentially keep up with that, which would be ridiculous, would just be to get, serial MRIs to try to prevent or think we could prevent anything from happening, which probably wouldn't work anyway.
Yeah, I think that would be a disaster on
Uh-huh.
in many ways.
Yes.
Um, okay, so we have a good idea of how to spot them. We know when to offload them and for how long. We know that we should not be dealing with a lot of pain or any pain during our rehab. Let's say they get out of the boot or off the crutches, they're ready to start loading again. We know that we have to monitor their pain levels, but what is typically next?
Yeah. So this is where again it will differ, I think, significantly depending on the site and the person. But a general overview, we'll want to very gradually increase their steps. And we could do this also in a way that offloads that site of injury a little bit more. So if they're going directly from a cam boot to a regular shoe, that's a pretty big jump. So to offload metatarsals or tibia, kind of reduce plantar flexor forces, which create some load on those bones, then we would transition them into a higher drop shoe or a maximalist shoe, or a rocker shoe. So something that kind of weans them out. And similar for crutches too. If you're weaning off of crutches, don't just drop the crutches and go for a 15-minute walk. You can gradually wean them out. And so one day it's partial weight bearing. One day they're doing 25% of their day no crutches, the rest of the day partial weight bearing. And so having this be more of a weaning process over the course of a week or so is
Got it.
important.
Okay.
From there, then it's progressively loading, focusing on the weight bearing aspect. They may have been doing some non-weight bearing exercise during that non-weight bearing period. If they're a high risk athlete who is probably in an energy deficit, we're going to be less likely to do cross training or to do exercise during that recovery period because they need to get out of that hole.
Can I ask you a
Whereas if
question
this
about
is,
that?
yeah,
But yeah, you're about to say whereas maybe if it was a low risk site, are the exercises that they're doing, let's say it's let's say it's like a tibial bone stress injury, are they doing like banded plantar flexion, or are we generally trying to also avoid resistance exercises that may load the site, and we're just doing other things that don't load it very much, like maybe some hip exercises, maybe lightly going on a bike just to get their cardio up?
Yeah, great question. So for those first 3, maybe 4 weeks, we want to avoid contraction at that site of injury.
Got
So
it.
for example, a metatarsal or tibial BSI, you could still do calf raises, plantar flexor exercises on the unaffected side. That may help with some crossover effects, maintain some strength on the affected side, but we're really trying to avoid additional strain on that bone. So those first few weeks, you can do non-weight bearing exercises like you could do sideline hip abduction, something that doesn't contract the plantar flexors, but you do want to avoid contractions at the around or at that site for the first 3 to 4 weeks.
Cool. Okay. Got it.
Yeah. And then in terms of other cross training, yeah, you could bike. I would encourage not standing. If we have the site of injury, we were just discussing metatarsal, discussing, not discussing, discussing. We were just discussing the site of injury as metatarsal or tibia. So just thinking forward of like what is going to cause some additional plantar flexor loads, what's going to cause some bending forces at that bone. Those are activities we want to avoid. They'll probably have a pain response, but we can be intentional about those things before they do. But if they have an injury at a low risk site, they're probably not in an energy deficit, or we've already cleared that that's not the case here, then they can cross train through it.
Got it. Okay.
And then after those, so that initial phase, then we're going to progressively load into like double leg exercises, then progress towards single leg, and then add some impact tolerance exercises, but gradually load those too. So partial weight bearing first. Some people in clinic have like a shuttle jump. You could use a band to assist. You could just use a countertop to help. But gradually progressing their plyometrics from an assisted double leg to double leg, assisted single leg to single leg. And the timeline for this is going to vary significantly depending on the site of injury and the individual's bone health.
Right. Okay. So are you basically looking not necessarily at a time-based return to run in those instances, and more so their progression through their exercises and how well they're tolerating them?
Yeah, and I'll typically kind of use the timelines that are typical that we talked about. Um, Generally add a few weeks because the return to
Yeah.
sport timelines are based on athletes from a wide variety of sports. Athletes in sports that aren't running tend to have higher bone density. Since bone density is a predictor of return to sport time, I think those timelines are probably too short for an
Yeah.
average runner. And then if they've got a history of BSI, low bone density, restrictive eating patterns, we're going to add a few more weeks. So then I'll kind of break those down, that timeline. Let's say we're thinking 24 weeks to return to run. Now let's break that down into segments. And so we're only going to be working on double leg progressions for 2 to 3 weeks, maybe if it's a low risk site, 4 to 5 weeks if it's a higher risk site.
Got it. Okay. And Steph, in your experience, let's say you're trying to progress somebody's plyometrics and you started with the banded or the shuttle jump, sort of like a type of 2-leg jump where there's some of the body weight that's taken off of it, and you're logically progressing through it and everything's been great. And then you try to do a single leg jump and they have pain at the site of their injury. Uh, Firstly, does that ever happen? Secondly, if so, are you saying, oh, I guess their bone stress injury or stress fracture is sort of still there? How do you think about it and how do you communicate that with the patient? And then what's the actual action that you take? Do you just step back and keep doing the 2-leg jumps?
Yes, this definitely does happen. And I think it can be easy to freak out and think that their injury isn't healed. But that's not necessarily the case. I think of it more as this tissue was overloaded from this new stimulus. So we're going to back off, give it a break. So from any of the activities that we know will put additional demand on bone. So if they're doing a walking program at that point, we're going to take 2 to 3, maybe even 5 days off of their walking, off of their jumping, and then start back with the double leg before we go to that single leg. So start back with the one that was tolerated, do that a few more times, and then try single leg again. So kind
Yeah.
of like, all right, we pushed it a little bit. Generally, that will resolve in the next 24 to 48 hours, and then give them a little extra time before they go back to that lower level. But it can be discouraging for sure. And I think it's important that we know that this is a normal part of the process. And it doesn't mean that they need to start back at square one. We just need to take a little bit of time before we get back into the program at a little lower dosage level or lower
That's
intensity.
really good to know. I like that. I like the point about actually offloading a little bit relatively instead of just saying, "Oh, we're not ready for single leg jumps. Let's just do two leg." They may not be ready for that just yet. So actually saying, "Let's let things calm down for a few days and then we'll get back to where we left off." I think that's great. And also normalizing that flare-ups can be normal. They're not ideal, but we can navigate them. It doesn't mean we have to start at square one, I think is something that would be really encouraging to hear.
Yeah,
Yeah.
especially with how long this recovery can be. A lot of times it's smooth, 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 and then there's a hiccup, and it can be super discouraging because that goalpost for when I get to run continues to move.
Yeah. And let's say we're very close to that goalpost now. And it's been a long time and we can't wait to get back to running. Steph, when can we start that again? When can we've been doing the plyometrics. Can I start running now? Is it like on off type thing where I'm going for 1 minute and then walking for a minute? How do you typically program someone's running when you feel ready clinically that they could start it again?
Yeah, great question. So I'll have them do a couple weeks of doing consistent brisk walking. So rather than like elliptical machine where you don't have as similar muscle forces as you would walking to running, I'll have them tolerating 30 to 45-minute walks 3 times a week, as well as go through a progressive plyometric program to where they're tolerating single leg hops 3 days in a row before we start the return to run. So generally at that point, I think that combined with an appropriate timeline for their grade and site of injury. That has worked pretty well. And then we start with a very individualized walk run program. So generally, it's going to be a minute on, 3 to 4 minute walk times 3 to 5, depending on again how conservative we want to be with this athlete. And then very gradually working up. I don't think that it makes sense to follow, the 10% rule has kind of been debunked. And when you're at that low of volume, it's really hard not to increase by more like 20 to 30, even sometimes 50%.
Yeah.
Um, when I'm programming it, I'll try to avoid in those first few weeks going over a 30% increase in total running minutes per week. So I, have it added up and then have a deload week every third or fourth week where we cut it back down by 20 to sometimes 50%. So
Awesome.
kind of this build, come back, build, come back. And the rate that we build again is very dependent on the athlete's history, site of injury, and grade of injury.
And speaking of rates and their return to running, what do you typically say to someone if they're at the start of their journey and they're wondering if they're going to be able to get back to running? Would you say that if it's managed well, a lot of the time we could have success? Do people not often succeed with rehab? What's their success or their probability of success looking like?
I think the probability of success is very high, but the timeline might not be what they expect.
Yeah.
So if someone has a high risk site of bone stress injury and they're a marathoner, I will suggest that I wouldn't recommend racing a marathon for a calendar year until after that initial injury. Um, I think the rush back is one of the reasons why the recurrence rate is so high. And especially for athletes who have, they've gotten really fit, they had this goal race, now they feel like all their fitness was lost. And truly, you do become more deconditioned, especially with these high risk sites. We just have to. And then they're trying to get back to that goal race. The majors are challenging because there's such a commitment for people, but they're trying to get
Yeah.
back to that goal race. Running for quote fun is a nice goal, but it's not always what people want to do. And so they might push themselves a little bit more. They notice that they're deconditioned. And because we've had this period of time where they've been offloaded, this spike in both volume and intensity can increase the risk for another bone stress injury. And I think just from anecdotally from my own experience, and then the Pop et al. Study that looked at bone density as athletes recovered, they found that 33% of their subjects had another bone stress injury in the year following the study. And I think that first year is really important to regain consistency with volume, because it does seem like within that first year after someone's first bone stress injury, they often do get a second.
Yeah, even at a different site, right?
Exactly.
Yeah,
Yeah, it could be recurrent in the same site or at a different site.
got it. Okay. Well, we spoke about risk factors. We spoke about the questions that we might want to ask somebody, what sort of tests to do, and the other signs and symptoms someone may have. We spoke about when to get imaging and when to refer out, and also the offloading period, what to do during that, and also how to progress rehab after, and sort of the return to sport process. So I think we covered quite a bit. And I know personally, I feel more comfortable now if someone was to come in through the door about spotting and knowing how to manage a bone stress injury. But is there anything else, Steph, that you'd like to add before we wrap up here?
I don't think so. I think the biggest thing is for us to start to gain awareness not only of the prevalence of bone stress injuries, but also the factors that can contribute to them, and then play a role in referring, because this is generally just a knowledge gap, not only I think in the misdiagnoses of these injuries, but also in athletes underfueling. Most of the time, it's unintentional. So
Yeah.
just I think it's great to be able to be on here and talk about these, so that more and more athletes can benefit from practitioners who have this knowledge.
For sure. It was a pleasure having you, and thank you for sharing all of your knowledge with everyone. I really, really appreciate it. And just so that people can continue to learn from you, where can they find you and where can they follow you online?
I post on Instagram most probably, Steph Mundt .dpt. It, we probably can link it. It's a
Yeah,
lot of
I'll link it.
consonants. Should have put a vowel in there somewhere. But I talk about bone stress injuries a lot on there. And then from there, you can get to my website, and I give my email as well.
Awesome. Okay, cool. Steph, thank you so much.
Thank you.